Good evening to the December 18th regular meeting Board of Directors. We'll start with a call to order, and obviously any reports of actions taken in closed session. Somebody, please.
So excuse me. The board considered 3 items in closed session this afternoon. First, the board voted to approve the closed session minutes from the regular and special meetings held on November 20th by a unanimous vote of the 4 directors present. Second, the board held a conference with its labor negotiators regarding negotiations with the Employees Association and Employees Association of Professionals. No reportable action was taken. And last, the board held a hearing pursuant to Health and Safety Code Section 32155 to consider medical staff credentialing, and the board voted to approve the medical staff credentials as recommended by staff by a unanimous vote of the 4 directors present.
Thank you very much. Any deletions or corrections that need to be announced at the posted agenda? I don't see any. So we'll go ahead and continue. Welcome, audience. This is an opportunity for anyone in the audience who'd like to speak. To the board, items are not on the agenda. Please state your name for the record and comments left of 3 minutes. If anyone would like to speak. All right. We'll continue. Any input from the employee associations? You please do.
Yeah.
Welcome.
Hi.
Hello.
Haven't seen you all in a minute. It's hard to get out at 6 p.m. when you're my age. Be home in bed.
Your age. Break.
The phone? Okay. Thank you for having me, you guys. I just wanted to give you an update about what a great time we had during negotiations. However contentious it might have been, our relationship with management as labor continues to be forward-moving, forward-thinking, with the concerns of labor foremost in our mind and concerns of the district also foremost in the negotiation team's mind. So it was a very well thought out, lengthy, long conversation day after day, week after week, to get us to this final contract. And we just want to say that we're really pleased with the final contract and happy that it was passed by the board. We worked very hard on it. We do believe that we were fiscally responsible in our requests and our negotiations. It was very good faith bargaining, and we appreciate everything that the district does for us. And we continuously remind our members to have grace and gratitude as we move forward into this contract, which begins on January 1 of 2026, as it goes to our membership to vote. If they vote it in, then we will all be very, very happy. We do not want to go back to the table. So just wanted to let you guys know it was a good, healthy negotiations, and kudos to the team, and especially Lauren Caprio, who led us in that negotiation. So thank you so much for having me.
Thank you. All right. Item 12, our monthly report from our President and CEO, Anna Roth.
Thank you. I think Sarah's pulling up video, and I will call on Kim McCarl in a few moments, but I first wanted to say welcome to our last meeting of the year. 2025 was a year. I do want to just acknowledge that if you have a moment, and we'll try to have Sarah send that, but we did celebrate many people who hit really large service milestones earlier this month, and there's a video, and we'll make sure the board gets that, and we will try to figure out a way to get that posted on the public web. The other thing I just wanted to say is we also had many people join this year, me being one of them, join the Tahoe Forest team, but we also really want to recognize and celebrate those people who actually have sailed into retirement at the end of this year, or even throughout the year, because we actually haven't sort of paused to acknowledge that. And there are many, many people that we're very grateful to, that they spent they did their life's work here at Tahoe Forest. Several, hit 40-plus year milestones. So I just want to acknowledge that, and say there's too many actually to list, because this is such a tenured staff, which is a really great sign. So I just wanted to start by saying how grateful I am to begin my next year on this team, but also for those who actually spent their life working on this team and now are going to be on team community member, retired community member, which makes them emeritus Tahoe Forest staff. I'm going to give you a few highlights. I'm going to actually move through these because you can see we have a packed room tonight, which means we have a lot in store, a lot of really awesome things in store for the board tonight. I'm going to start with the third next available. So this is really our gold standard access measure. Again, this is, I will just say that you do see a drop here, but this is a seasonal drop that we see actually every year. So I would note that though the team is working really hard, statistically, we don't know that this means much more than a seasonal change, and we will be bringing you back much more information on this coming up. We are looking at a full sort of rework of the third next available efforts, and we'll bring you an update in January because I think we're going to have some significant updates that are coming around kind of the team that we're going to be tasking to kind of work with the teams that are already working on it. And I think we do anticipate bringing in some external expertise to work with us specifically on third next available. And I think we will start segmenting that, and you can anticipate that we will probably start at primary care. So again, we'll more on that very soon, but I do want to keep this in front of the board and the public that this continues to be a area of focus for us. That said, I do want to also say there is some things happening, and so I've given you an update. We did institute a couple of new technologies, one called Fast Pass, and that is essentially where you can call in or you can access us and you can get on like a wait list, and then when an appointment is canceled, which happens all the time, it's happening all the time in the appointment center, you'll like get pinged, kind of like does anybody have those camping apps where you're trying to get into a really popular state park and you get on the list and then it texts you, but then you have to text back and you have to actually respond back and get it. So you're in a line, so you might not actually get it. It's kind of first come, first serve sort of thing. But it has, as you see, for those who have used it, these are the numbers of days waiting that we have eliminated for the people who have used it. We've only had actually 66 people use it. However, if we could increase that, then we might see even more, if you will, days saved. And those are basically, that's how much weight we have eliminated out of the system for those people. Again, if more people start using it, you might see some of that drop down, the average weight sort of drop down because there will be more people participating. But the other side of that is we are expanding the use of it. So I think you'll see that rolling out more and more in the coming months. And if you don't know about that, then there's a lot of information available, both in my chart as well as on our webpage. So.
Excuse me, when you talk about more people participating, are you talking about more patients or more providers?
More patients. All the providers' schedules are actually loaded into this. So, all of the providers' schedules who are in the departments that we've rolled it out to. So we have not rolled it out system-wide yet, but as you see, we've rolled it out in pediatrics, and they've save the most days, if you will. And then as you kind of go over on the chart, you can see family health, primary care, internal medicine. But we do plan to roll this out system-wide. It's a big change, so we're pacing the rollout.
So when somebody calls for an appointment and it's a lengthy wait, are they being advised by the scheduler that this is available?
I think so. I'm looking at you, Crystal. Yeah, we think they should be advised. Jake was just about to stand up, but we do think that that's what the scripting sort of says. The scripting says that. Whether this is happening 100% of the time, not sure, but that's our aim, for that to happen 100% of the time. It's almost like when you call and somebody says, if you want to get in line, push the button or whatever. Yeah. It's just a little more manual than that, but it's now a feature that we have available to our patients across some of the departments, with a plan to expand it across the whole system. Yeah. Okay.
That's a good question.
It's okay.
Does the patient have to have my chart in order to get this? I think they do. Yeah, I think that's correct.
Yes.
Yeah.
They do, but is it going to be text-based at some point? Yeah, so this will keep expanding and actually simplifying and being more intuitive, because we do have the aim is for us to eventually move it across all the departments and have it be text-based as well as in MyChart. You'll always be able to access it via MyChart, but we do anticipate at some point in the future that you could actually do this all via text. We're not there yet, but we're headed there. Yeah. I just wanted to talk about, the snow is going to arrive at some point. I know everybody's I'm probably the only person in the region that's okay without the snow being here, but the snow is, and we are preparing for that. I just want to recognize that our teams are working really hard to be ready to welcome all of the visitors, for those who are having sort of smooth sailing down the slopes and some who may need some assistance from us. And they have been doing training on the trauma protocols, and they have trained over 40 staff members at the 4 different local ski areas. So just wanted to make sure that the public knows we're ready and we'll be there for you if you need us. I also wanted to talk about the Every Woman Breast Counts cancer screening, to say that basically as we are aiming for, the goal is really to hit 80% screening, and we're seeing actually the lowest population are Hispanic women. So this subgroup, and particularly as well as low-income women, I mean, those 2 subgroups really are carrying a disproportionate burden around low screening rates. We have been working with our community health team, as well as Sierra Community Health, who has been working on a variety of outreach efforts that are also both culturally and language appropriate. So we will continue to monitor this work, but this is really an area that we feel needs a lot of focus. So again, we'll come back with that, but we wanted to give you an update on that. And we're very grateful to Sierra Community House, who is an outstanding partner with us. I wanted to talk a little bit about Community Health Lab access, and the reason I wanted to talk about this is that we'll be bringing you an affordability plan coming by the end of this year, before next fiscal year. But I also want you to know we're already working on that. And what this really indicates is that we have had a 44% increase in those community health lab appointments. And that really has to do with the staff, that we were doing them a few days a month in a couple of sites, and now we do them every day at every site that we have lab draws. So I just want to say we actually increased quite a bit from the 488 to 706, and this is really, the reason that this is so important is because this serves as the foundation for us to figure out how do we do this at a much broader level, particularly when we open the Sierra Center. There's so many nicknames for the clinics. The Sierra Center, which will really be one of those sites that we are really going to push to be sort of the hub for some of those affordability efforts that we do. Of course, we will intend to, and our plan will be, as we get much more sophisticated, to roll this across our system, but we really need to have a model site where we really want to go large. And so again, this foundational work is critical, and I just want to acknowledge the staff for this. This is a major gain. And one of the things that I heard about when I first got here was around affordability, particularly around labs and diagnostic imaging. So, I think the team needs a lot of credit and acknowledgement for this work, because this is new. So I really appreciate the work they've done there. Wanted to talk a little bit about the care transitions and the CMS 5-star rating. We actually got a 5-star rating. We are one of 204 hospitals nationwide. This is and one of 6 in California. This is so critical because transitions is one of the most vulnerable points in a patient's journey. Even if it's transitioning out of the hospital or out of care, it's an extremely vulnerable moment in the care journey. So the work that's going on our care transitions team sometimes isn't seen because maybe it's not on the floor. It's sort of in that space in between. And it's a very high honor, and I just want to congratulate them for that, and make sure the board is aware of that and our community is aware of that. You're going to hear, I promise I won't steal the thunder of the stroke team tonight. So, but I do want to say that we were accredited, and I'm going to leave it at that, just to say you're going to hear a lot more about that. But this is phenomenal work going on. And I think, again, you're going to hear more about the risk of stroke, but this is a very significant health risk for our community, and to have an accredited stroke program here is rare. It's exceptional, and you'll hear more about how impeccable this program is. I also just put a couple of other things up there. One is that I want to recognize our blood bank and our lab for working on bringing in the essentially blood products that are very critical, particularly for our trauma center. This is platelets and liquid plasma. Again, this is not entirely readily available in critical access hospitals, so I just want to acknowledge that. And then finally, I want to talk about, just end this slide with just a high note that we actually had 6 students participate in a job shadow program at Incline Village, from Incline Village Hospital, and you can see that they worked in a variety of areas, including emergency, DI, diagnostic imaging, sterile processing, and they did that through their fall semester. And I think they were actually they were just at Incline, right? They were just at Incline, yeah, at Incline. So anyway, really fun to have the students there, and hopefully maybe they'll be future Tahoe Forest employees, because hopefully they kind of got really energized by our staff. We talked about geriatric and really becoming a geriatric center of excellence, and the formal beginning of that journey will be to seek geriatric ED program accreditation. And we just want to make sure you know both of those applications for Incline and Tahoe Forest are in now. Thank you so much to both the foundations for covering the cost of those applications, and to the staff for getting those in such a timely manner. We have a kind of what we're calling this is called the JEDA program, GEDA, and we're going to have a JEDI program, JEDI, JEDI, as in Yoda, Star Wars themed recognition program, really, that you're going to start seeing roll out, where we really want to recognize those staff that are going above and beyond.
Star Wars fans that old now?
Yes.
Yes.
Yeah.
Dr. Koch, we're not going to go there. Because I actually asked, I actually did stop and clarify when I read this. I said, is this Jedi as in Yoda? They were like, yes. So, okay. Which I can get behind, I do want to say. And I would anticipate for those staff listening, there could be a trivia question from Dr. Evans about this. So, yeah, it's possible. All right,
Excuse me,
yes.
before you move off of that, not that I have a vested interest in the geriatric program,
Not that you do.
but what is the fifth care process?
Janet, can you speak to the fifth care process?
No, but Trent can.
Oh, okay.
Yeah, so the care process is,
Yeah, well, I just don't want to say it wrong, so Trent will have this nailed. Yeah. So.
am I on? Good evening. I'm Trent, Director of Nursing for Tahoe Forest. For the geriatric, our fifth care process that we're really focusing on is medication reconciliation, so ensuring that our patients have proper medications as they're entering the facility and discharging from the facility. So current process is hopefully by our next fiscal year, we'll have that in place. But the previous 4 to get the application started has been already approved. So that's our 5th care process, just better medication for our geriatric polypharmacy, lots of medication management and how to manage taking those medications versus duplicating and coming out. So really focusing on medication management for those patients. Thank you.
And we have a lot of confidence that we will sail through that because I just told you, we have a 5-star rating in care transitions, which this is really a part of care transitions. So thank you, Trent, for making sure we were on track there. We talked a little bit in October about, I just wanted to bring this back to the board. We joined what's called Credible Mind, which is a online platform. And it's really about access to support and tools around depression, resilience, stress, social support. And I just wanted you to know how many times actually this has been used. Since October, there's been 1,352 logged sessions. A couple of things I will say is that you don't actually have to be a Tahoe Forest patient to use this. You do have to go through, the detail is on you have to register through us, but you don't have to be. This is for our patients as well as the community, which is why we're doing outreach using radio, social media. We have waiting room and video monitors, but this is available to our community at large. And we're very heartened to see that people are using it because we know that many people want to access this kind of information in their own way, in their own time, in their own space. And so, again, I just want to acknowledge the behavioral health team for making sure that we brought in this kind of a resource for our patients, and as well as our community. So this is one of those things where you may not know exactly it's hard to measure things that didn't happen. But we can at least tell you that it is being seen as an important resource for at least 1,100 people have accessed it. So I'm actually going to call on Kim McCarl to talk about this slide, and I think Kim is on, although I can't see her from where I'm sitting. Is she? Yeah. Kim, are you there?
There she is.
She is.
There she is.
But now we can't see the slide.
Kim, can you?
Kim, we can't hear you. Okay, well, one of the things we wanted to do is actually have Kim test this out because, as you know, for the community to know too, the Brown Act has gone through modifications, and starting in June, we have to start moving towards real-time interaction virtually. So Kim was actually going to be a test case on that. By July 1, we have to actually have it reliably in place where public can call in and make comments in real time. So this is a learning lesson, but so I will take these slides for Kim, and just to say, you can put back the big slide if we can't get Kim, that's okay. Wanted to sort of lay out to you some of the community engagement progress towards our 5,000 voices. And again, we just sort of marched this out by month. These are just some rough numbers that we could easily grab. But again, I won't read the list to you, but just to say that this has been really, a lot of this has been the community forums related to the community health needs assessment, but also we're counting some of the work with the joint town council and the Nevada County public meeting that we had where we interacted with them. And then I'll just show you on the next slide, just so you know, because we realize these are very blunt sort of measurements and numbers, but we just wanted to kind of start tracking and figuring out how we might track this. So on the next slide, you can kind of see that we're starting to put together a measurement strategy. And again, I wish Kim was able to speak to this because she can speak more eloquently, but we are just putting together a spreadsheet that's going to start to track and count our way towards 5,000. And again, there's going to be ways that both, and I think Dr. Dozenkevich, you might have asked for, you wanted an actual, because I was like, she had in the talking points, like, it's a Google Doc. And I was like, I don't think we have to really say Google Doc. And she said, actually, Dr. Dozenkevich specifically asked for Google Doc. So we are going to liberate this tracking. And so again, this is really kind of a proof point to say what's coming. And also we'll be kind of testing this out with others to make sure this is feeling valid enough. Again, we have not done this tracking in the past, so we'll be keeping you posted and kind of put daylight on it as much as we can. And then finally, I wanted to just quickly, I promised to bring you back some training data, and this is just a glance from July 1 to December 1. We talked about we talked about some training and I couldn't validate the numbers. So these are numbers from HR, which really kind of tracks they kind of brought those numbers out of HealthStream for us. That's our virtual online sort of health education tool where you can go in and log in and take classes at your leisure. And then there is Management Leadership Institute classes that you can see there, and then the continuing ed classes through HealthStream. And then finally, we heard from the doctors group last month. They said they had over 100 people do HIPAA training. It was actually 180. So I just wanted to put some numbers up there to kind of some of the statements we've been making. This, for sure, is not an exhaustive list of the trainings. Like, I'll just tell you one thing that stands out to me. This does not include the escape room, the sepsis escape room that many of us did over the holiday, over the Halloween holiday. But it just gives you a sense of how much training is going on. And I do want to just take a moment to sort of say, if you had a chance, and I know I think Dale was there, we just had this week a very well-attended winter injuries symposium down at Incline, and it was a packed house. It was, again, I think, the work that's going on through our, the variety of people who are working on professional development and community training is astonishing. So again, I just wanted to put some numbers up there, and then I'll leave it at that. That concludes my formal remarks, and I'm happy to answer any questions. But we also have, if it's about stroke, that's coming next. If it's about cancer, that's coming tonight. We have some really great presentations for you tonight. So, thank you.
Thank you. Any questions, comments?
I asked mine, thank you.
You did ask yours, yes. Dale?
I've just got a question on the individual contacts that you're making in the community. Because I'm a board member and a lot of my friends know it, a lot of acquaintances know it, I sometimes talk to them and ask them in the Squaw Valley locker room or at the Rotary Club or wherever my contacts I meet up with. And a lot of times I don't get anything meaningful about comments about the hospital. If they're healthy and they say, no, I just want to make sure you're there when I need you. But that's about the limit of it. Is that still being tracked as a comment, as a specific comment made by members of the public?
We're not really tracking unless we're sort of asking in a little bit more formal way. I will just say, we've exceeded 5,000, if that counts. The amount of interactions I have at Safeway, I'll just say,
So in the checkout line,
we're really, and again, I wish Kim were on, but we're really trying to capture 5,000 voices as it relates to our true north, which may be that we end up institutionalizing like one of our core which I think is sort of embedded already in our core mission, which is like, we're here whether you're engaged with us or not. We're here for you and you can count on us. That is, so I don't want to understate, we definitely value even the informal, impromptu feedback. We're not tracking all of that, I don't think, because there's so much of that going on, but we really want to have a little bit more structured feedback. Can you hear me, Kim? Can we hear you? We still cannot hear you. Okay, so, but Kim is nodding, so I'm in the right track. But, and I do want to say that, I do want to announce a small change across the AC, and that is that Kim actually, in her role as Chief Strategy Officer, does have government relations and marketing and communication now reporting to her, and they're going to be working on a much more robust tracking of all of that, because they're doing a lot. Yeah.
Good.
So.
I just have two comments, and because you answered my question already. One is, thank you for continuing to bring Third Next Available to this meeting and letting us know. I think, I'm excited to hear, I think, as you mentioned, like a rework in January, teams and external, internal, and you said start segmenting, trying to figure it. But thanks for just listening and just bringing already something with FastPass, and thanks to Jake and whoever also is involved, or even using technology to just get people to see their doctors. I mean, 42 days for pediatrics, and that was quick. I mean, yes, it's 66 patients, but again, to move that forward, and along with the hard work to reorganize and look at all this, to rework, as you said, thank you. So I can't wait till next year, in January as well. And then the other comment I wanted to kind of make is, I don't know if we can, Sarah, to focus on that sign over here. It's called, we'll call it Starting at Young, based on the comment of the Youth Job Shadow Program at Incline Heights. So a little thank you note from, thank you for supporting Truckee Elementary School from Mrs. DePue's kindergarten class. So starting early, I mean, as a physician, maybe a little, I'm sorry? Yes, it counts. If they can do the Google spreadsheet, they're in. But starting them and then going to Incline, I'm reminded of, even having internships and in the summer, how we had people at that level as well. I had coffee with Craig Rowe, who, as many know, has been nominated as TTUSD Teacher of the Year and actually California State finalist, who is a champion for students. And we talked about children and youth, and we talked about getting them involved. Kids want to return. His point was really fascinating. I found that he goes, Rob, kids who go to college, they want to come back. But the job market's hard. It's hard to come back here. It's hard to come back professional. It's hard to come back even if you leave high school here and find a job. And so, nothing for us, but I do love the fact that we have at kindergarten. We're starting them early. We have high school. We have internships. So it's just a thought in my head as we go forward to help our community. How do we really integrate the youth? But so thank you. So thank you for this presentation. I have no further comment.
Will we be hearing about the Third Next Available on a monthly basis, or how frequently will we hear that?
That is what I keep bringing it, because I was asked to bring it on a monthly basis, and I would say it is a very high interest to the general public too. So I do think it's unless you direct me not to, I'll be bringing it to you.
Please do.
Yeah.
Thank you.
Yeah.
So you've heard about it the last few months, and that's purposeful.
Thank
Yeah.
you.
Okay. And public, I believe, any comments or questions? Okay. All right, let's continue on then. Thank you very much. All right, on to 13.1, Medical Executive Committee, Meeting Consent Agenda. Dr. Koch, we have a new policy and some policies with changes.
Correct. So we have a new policy, which is the refusal to permit care or treatment. And we have this policy because there are times when a patient wants to refuse a specific treatment but not refuse all treatment and not leave the hospital. So currently or previously, patients would sign AMA forms to say that they didn't want to get an antibiotic or a vaccine while they were in the hospital. And that wasn't really correct. And so this policy provides a different form that they can complete and say, I want care here, I want general care, but this particular thing is what I don't want. And so that policy is just to make clear when a patient is signing a declination for services, whether they're signing for all services versus just specific services. The AMA form didn't allow for that. Okay. Questions on that one?
And that's, again, for, anyway, against medical advice, right, for that.
Well, so AMA is against medical advice, but the declination of a service is not an AMA action. No, it's just a patient choosing to decline services.
Or a
A service, correct. Against medical advice means leaving the hospital and refusing care, and that's not what these people are doing. Yeah. There was also a question about that policy relating to, do we have experts on our medical staff that can determine if a patient has capacity to make that decision for themselves? And in our policy, it talks about the attending physician being the one to assess capacity. And if they have questions or doubts about capacity, we do have our telepsychiatry department, we have our behavioral health department. We have psychiatrists on staff where if the timing were correct, then they could be made available. They would come in as well. So we do have resources for expert opinions on capacity as well. All right. Next is the policies with changes. Then there's one credentialing and privileging policy about proctoring, and it just defines more clearly than we have in the past what proctoring looks like for a new provider or a new procedure or a new thing being done in the hospital. So this specifies exactly what that needs to look like. It does leave flexibility for different types of privileges, but it generally specifies the requirements of a proctoring program. The next group of policies are all women and family policies, and there are a number of them. None of the changes were earth-shaking, and I don't know how far you want me to go into those. There were some changes that were meaningful, but they were all described in detail here. And again, I'm not sure you want me to go through each of those. Do you have some questions? Do you want to
I
approach
think
that?
that's perfect time to pull up and ask us, because I was thinking the same thing. It's
Yeah.
like, that's a lot to read. So,
Yeah.
I mean, we read them, and I didn't have any questions,
okay.
but I just want to just make sure, just because people who looked at this or people who may have read in the public, there's a lot of labor and delivery, and is it because we're looking at each department separately? Like, this is their turn to look at it? Is there any big changes for that? I'm trying to think of any questions the public would have.
So no, I think that's an accurate description of why.
Okay.
Yeah.
Okay.
But do these policy changes meet some sort of a national standard, or?
Some of them are just correcting things to reflect what we actually do, and some of them are updating our policies to either meet standard or to meet things that work better for us and better for the patients, improving patient care. The next group is emergency department policies. Again, same thing. There were a number of changes. And I don't think you want me to read through them all. Again, none of them I thought were earth-shaking. I'm going the wrong direction here. And then the last group was nursing services policies. And again, that was a large number of policies, but very few significant changes. Mostly formatting or small additions or subtractions. Any of those you'd like to go over in detail?
No, thank you.
Because we already know
Excellent.
they've gone through the
Please, no.
department, they've been passed up to med staff already,
Correct.
and so now they're coming to us. So we've had levels of review already on them.
Correct.
Expert review.
Expert review.
I was just going to say,
Dale, you're giving your expert review?
yeah, my expert review doesn't count.
No, I think they're good. And just as an example, as a physician, like I thought, in reading the refusal to care, it was interesting. I had a patient yesterday I was trying to keep convinced to stay in the hospital, and reading this, it's a good primer. It's a good refresher. As a clinician, I look at it like, oh yeah, I did that. oh yeah, this is what we're supposed, but it's nice to have it as written down as a policy. So it's, again, all the other ones on the side I couldn't speak to, but it just makes sense that, you have these policies so people can look at them and say, oh yeah, I am doing everything right for this patient in the moment. Because when someone says, I refuse, I don't want this antibiotic, people can get very emotional, but if you have a policy that's set in place to say, oh, I'll just follow the policy, it becomes just what we're trying to do right for the patient. So, thank you.
Yep.
All right. Any other further questions, comments? All right. This requires a motion, correct?
We need comment from the public.
Oh, I'm sorry.
Public comment.
Any public comment? No? Nothing? None? All right, then. Thank you. All right, this is for a motion, then.
Okay, I would move that we accept the Med Executive Committee consent agenda as presented.
I'll second it.
All in favor?
Aye.
Anyone opposed? All right. So approved. Thank you. All right, we have a consent calendar. These items, looks like we have 4: approval of minutes of meetings, financial reports, board reports, and ratify Tahoe Forest Health System Foundation board member. So these are typically not to be routine and non-controversial, so they can be acted upon the board without discussion. Of course, any board member, staff member, interested party may request an item to be removed from the consent calendar, and we can discuss it later. So any motion?
I have nothing to pull.
No.
All right, then, let's go ahead. This requires also a motion.
I move
Comment from the public.
Well,
public comment.
I kind of looked at them, but I will look at the public, let the record stand. I made a long gaze to the public, but I will also verbally ask the public if they have any questions. And I'm going to say no, they do not. So, I'm sorry, who made the first motion?
I'll move approval of the consent calendar.
I'll second it.
All in favor?
Aye.
Anyone opposed? All right, consent calendar is from there. All right. Now we have some good items for board discussion. Looking forward to these. So 15.1, the 2025 Gene Upshaw Memorial Tahoe Forest Cancer Center Annual Report. Dr. Reichert, thank you so much for coming.
I just want to make sure this is working.
Yeah, press the button, red light.
Oh, I think is it on now? Okay. All right, thank you so much for having me here this evening. We have our cancer representation here, so for the public comment and the board questions at the end. So this is my second year here presenting our Gene Upshaw Memorial Tahoe Forest Cancer Report. This is for 2025. I'm Dr. Sonia Reichert. Kelly Bottomley, unfortunately, was unable to attend. She's our coordinator of quality improvement and outcomes accreditation compliance due to family obligations. So let's move on to, do I have the slide? I can control this. So agenda, just wanted to kind of keep us on point for what we were going to discuss tonight. I just wanted to recap our program, talk about our performance and quality highlights for 2025, and specifically review some quality reports, nursing reports, research and financial navigation, and future planning. So I thought it was an opportunity for us to actually kind of take a step back and talk about the origins of the Gene Upshaw Memorial Tahoe Forest Cancer Program. And this is something that has a really wonderful history going back to 2006 when Dr. Heifetz, who attempted to retire up here in Tahoe Forest, in Truckee, but learnt of a need for cancer care and started seeing patients across the street. That was 2006. 2007, there was already a brewing movement for cancer care within the community. And 2007, the hospital board actually approved unanimously for a Measure C bond funding, which became the seed money for the cancer program. A cancer advisory committee, a council of 29 members from the community was formed to really create the vision for what a cancer program would look like here in Truckee. And so that was formed in 2007. And then, unfortunately, 1 year later, Gina Upshur, the Hall of Famer Oakland Raiders, who lived for 35 years here in Truckee, passed away from pancreatic cancer. And so, the legacy of Gina Upshur and Terry Upshur's involvement in creating a cancer program was instrumental in ultimately forming our Gina Upshur Memorial Cancer Center. So it was a $34.6 million building, and it was launched in 2012. So what is the vision and mission of our cancer program? It has always been to deliver cutting-edge, patient-centered oncology care through a collaborative team model, academic partnership, and ensuring that we have high-quality care for our regional community. So what that means is that we have access to cutting-edge care. Everything we do is new and current. We care about the patient, and we do something called patient-centered approach, where we really put the patient in the center and revolve our treatment and team around the patient. We collaborate. Collaborative care model means that we are in constant collaboration and have built in the structure of our program to do so. We have local access to, patients have local access to national quality accredited centers, and I'll just sort of talk about that through our accreditations that we have. And the collaborative supportive services that we have is really unique to Tahoe Forest. This slide is, in previous years you've seen sort of multiple variations of this slide. I've consolidated it all into one slide, so you'll see that it's sort of the Cancer Center milestones since 2006. On the very left, that's Dr. Heifetz seeing his very first patient, and sort of the tracking of the number of patients over the years. And so if you kind of squint, you can see there's this steady line that goes upwards. There's a little bit of an up and down for different staffing reasons and for COVID, but we're still actually sort of steadily increasing the number of patients we see year over year. And you can see different kind of milestones where clinicians, physicians have joined the practice. And then that box is the opening. So 2012, the right-hand side of that box represents the opening of the cancer center, the Gina Upshur Cancer Center. Viewing kind of our patient visits over time a little differently, the blue line is representing the medical oncology patient visits, and the orange line is representing the radiation oncology visits over the years, and that's been tracked since 2017. And then kind of just to recap, what kind of patients do we see at the cancer center? So our patient catchment area is actually very wide. We really kind of look at the Sierra corridor. 50% of patients are in the North Lake Tahoe region, 25% in South Lake Tahoe, and 25% other. That's that corridor. So we truly, genuinely see patients across that whole spectrum of distance. So it's very unique for a cancer program to do so. This is representing different kind of sites. So we have very distinct, unique needs in the patients that are coming from North Lake Tahoe, South Lake Tahoe, second homeowners who come to get care with us, and then patients who are kind of on the Sierra Crest.
Do you have a deep dive on what the 25% other is? Where they come
that
from?
would be, it's a smattering of different things. So we have patients who get care coming from Sacramento, from the Valley. We have patients coming from Nevada, so a fair proportion who come from Reno, people who come from San Francisco, Southern California. I mean, really is a smattering of a lot of different places.
I would imagine, particularly if they're second homeowners here. Yeah. Okay.
Yep. Sorry, I forgot to. Western Nevada was the last one. So our current program, this is just a list for reference of how many people kind of make up our program. What I don't have on there is a line item. I was running out of room. It was our nurses. We have 18 on-staff nurses as well. So I wanted to give a moment of credit. Our program truly could not be what it is if we didn't have the strength from our partners. And I really wanted to give a a special thank you to all the partners that make us the strength we are. Number one being our community. This is a very unique cancer program to have such involvement from the community. That's philanthropic, it's engagement. We listen to our community, we have them be a part of what we're doing, and they have really strengthened what we do. Our board of directors who give us stewardship and advocacy, our leadership and executive teams, and Dr. Evans has been really supportive of us in these last few years to provide us growth and capital planning, and of course the foundation, which provides funds for our supportive care program. And then from a clinical standpoint, we have such a strength with our clinical relationship with our DI department and Briner Imaging. And I'm not sure if it's ever been stated before, but it is such a unique hospital to attract the kind of talent we have, to have this number of subspecialists who can provide care in kind of a small community hospital practice is really unique. So having specialists in multiple specialists in ENT, GI, surgery, neurology, pulmonology, urology, endocrinology, it's really unusual. And our relationship with pathology that has been is on speed dial with us and giving us a really accurate pathology reports. So program successes in 2025. We've had just over 400 new cancer diagnoses in 2025 at Tahoe Forest. We successfully completed 2 major program reaccreditations. We launched a new multidisciplinary tumor board format, and that was based on kind of understanding the needs of what our program needed and how we wanted to collaborate with each other and discuss, in difficult situations more real time. So that was launched this year. We are now reporting on additional quality metrics to national measures. We've expanded our financial navigation program. We added an extra 1.0 FTE this year. And we've done sort of hard launched quality projects, an oral anti-neoplastic therapy program, which also had a new FTE 1.0. We've hard launched formal pregnancy testing as part of our policies and processes. We've also launched more recently some additional infectious disease screening and further strengthened our psychosocial distress barriers. And then obviously staff education and competency training, that's kind of core to any program. But just to call out how complicated oncology can be, when I submitted this slide deck last week, there were 52 new oncology FDA approvals up until, and that number's changed. So we've already had several since last week. Yeah. So it is ever changing, and to have a program that can be nimble enough to be up to date with this requires a lot of internal training and keeping our fingers on the pulse. So accreditation and membership. And so with respect to accreditations, I just want to remind that when we do accreditations, this is a voluntary process. We do this as a program because we want to compare ourselves to the national level, that we keep ourselves honest about what we're doing, that we really are measuring ourselves and internally reflecting our program. And so we are high achievers. We have several accreditations, and that's listed here. I want to kind of call your attention to this bucket here. So this bucket, which is the Commission on Cancer, formerly known as ACOS, the American Society of Clinical Oncology, ASCO, COPE certification, and the Radiation Oncology ASTRO certification, are 3 very major and intensive accreditation programs. This is kind of like a triple accreditation, and this is a rare event for any cancer program to have all 3 of those. So to give you a kind of a flavor of how many programs actually have this accreditation, there is none in Renown, there is none in Sacramento. UCSF does not have all 3 accreditations. The kind of closest would be in LA. And we are, I really want to draw the board's attention to Dr. Semrad, who really represents us on a national level. This is a unique situation where we have Dr. Semrad, who sits in Washington, D.C. As the chair of the ASCO Quality Oncology Practice Initiative Steering Committee, and he's very instrumental in that role and brings all of that knowledge back to us. And so we're really grateful to have that kind of, that excellence in part of our program as well.
Hey.
So COC, we had accreditation this year, as well as the Astro, both of which we were recognized as being exceptional in our program. We have an ongoing Cancer Link accreditation that we report our national quality measures. We have an affiliation with UC Davis for clinical trials, and we have the Bonnie J. Odario Lung Cancer Center of Excellence membership. Okay, so COC is probably our flagship membership because it is really probably the most comprehensive membership you can get for cancer care. I didn't include all of the measures. There are dozens and dozens of different points that we have to submit data on. But what I did want to show on this slide was really that each of the measures are speaking to different components of cancer care, which begins at the cancer prevention level through screening, diagnosis, treatment, and then recovery. So each of these, our program has to answer to, report to, and have a robust plan for as part of our membership. And we're measured against all of these different components. So our accreditation this year, our site visit was on September 22nd. We exceeded our national quality measures, and we were praised for our quality outcomes. And I just want to report the quotation from the surveyors who provided this in their final report. So the cancer program at Tahoe Forest Cancer Center continues to provide exceptional care to the citizens of the region. The Cancer Committee has engaged physicians and providers, as well as participation and commitment by hospital leadership. Notable strengths of this cancer program include fulfilling the COC standards, palliative, rehab, nutrition, outreach, prevention, and screening teams. There is excellent collaboration between the cancer programs and its academic partner to deliver optimal cancer care to the region. Overall, this is a high-performing cancer program, and it was a pleasure to visit the center. So we were really grateful to have them, and we were happy with their comments. Another recognition that we received this year, which we were also grateful to receive last year, is the Press Ganey Guardian of Excellence Award Winners Circle. This requires that you actually have patients providing feedback on their survey scores of greater than 95th percentile across the country or higher. This is a really hard achievement to obtain. And so just to give you a flavor for, and this is published on their website, so how many outpatient oncology practices have actually achieved this particular recognition? That is it, just a handful. I apologize, this is Tahoe Forest Hospital District. We will change that to the Cancer Center that is specific to us. So, so this was a really happy recognition for us. Moving on to our Commission on Cancer, our COC, just to give you a flavor for the type of data that we submit. This is a slide that shows you specific measures, the expected performance rate, and how we measure compared to the state and to national programs. And as you can see, we really far exceed the expected state and national performances. Okay, and then other parts of our program that every year we do quite a number of different studies, one of which I wanted to just briefly show here. We do a genetic counseling and risk assessment study, so assessing how well we're actually doing genetic testing on our patients. We elected to look at a portion of breast cancer patients called patients with triple negative breast cancer. And so we looked at a data set of 3 years. This is a kind of a very small group of patients who have this condition. 23 patients were evaluated. 21 had genetic counseling. 1 patient refused, and 1 patient, we don't know if they had counseling, but I will just caveat that it was a patient who was initially diagnosed at another center and transferred to us. That patient did get testing, but we do not know if they had counseling. So not quite in our control. The second slide here shows us of those 23 patients, 22 of them had that genetic testing, and 1 was found to have a genetic predisposition to breast cancer, which had implications to her care as well as her family. And then CMS, Star Bundle, we heard a little bit about that before, about our 5-star rating. So one piece of that is actually through the cancer program and specific around emergency department visits, administration, or admissions for people who have received chemotherapy within 30 days. So this is the CMS definition. So if you've had an unplanned hospital inpatient admission or emergency department visit for any of these different complications within 30 days of outpatient chemotherapy. So the CMS belief is that if you've got a hospital with a lower rate of unplanned hospital visits following chemotherapy, you may do a better job of preventing complications and providing follow-up care. So our goal is less than 5.4% in this measure, and you can see on the left-hand side that we have continued to remain well under that measure, under that goal of 5.4%. And we really think a lot of that has to do with the right-hand side there, that which is the extensive work that we do and our nurses do with chemotherapy teaching. So every patient, you can see that's 100% of all patients who receive chemotherapy get extensive teaching, education, and follow-up advice and care, such that we think this is actually instrumental in keeping that number under 5.4%. Nursing quality and training. This is by our lead oncology clinical manager, Katya, and our lead cancer infusion nurse. They had reported out basically a list. I'm not going to go through this. I just wanted to give you a flavor for what our nurses do on an annual basis for competencies. So on the left-hand side, you'll see system-wide competencies, sort of the drills and events and research competencies, and on the right-hand side you'll see oncological specific competencies. So they track this, report on this as part of our cancer committee, and very extensive, and we are grateful to have such an engaged nursing team that really are on top of this and stay well above the national expectations for this. And to prove why I say that is that our nurses are so engaged. They are very up on certification. The national average to obtain something called the Oncology Certified Nurse, or the OCN certification, is 30% across the country. We have 72% of our nurses who have this OCN certification. It is not an easy certification to obtain, and so we're really grateful for their expertise. 100% of them are chemotherapy biotherapy certified, and they all have access to the National Cancer Template for chemotherapy subscriptions, as well as a part of professional organizations. And then you can see kind of other line items of other professional conferences that they attend. Regarding our clinical trial program at Tahoe Forest, Dr. Semrad leads this through UC Davis collaboration, and we have Ray Heaps, our clinical research coordinator, who's been a tremendous value add to our program. We are one of 4 affiliations with UC Davis for research. And we're currently managing 37 research patients. That's a mix between active and follow-up, a little bit more in the follow-up at this time. That's largely related to some of the research, the actual research trials that we've had open at the moment. We expect some of that to change as we've got some new ones coming up. Our current research portfolio, we have 9 studies that were reviewed for activation through UC Davis. 2 of them were activated, 2 of them are pending activated, and 5 were not thought to be appropriate for our patient population. And we currently have a study portfolio of 18 active studies, 16 active studies, 16 open to accrual, and 3 are on hold from the sponsor. Financial navigation. We have 2 financial navigators, Sonia Gustin and Coco Zarate. The Coco is the additional FTE that we added this year. And this slide is a really impressive slide. Last year I was impressed and I was grateful to present the kind of, you see on the right upper side of the screen, the total copay assistance last year was $213,000, and I was really impressed with that, and I brought that here. They blew it out of the park this year. We've been able to capture over $500,000 in copay assistance for our patients. So the addition of 1 extra FTE has really been instrumental in supporting patients. In addition, they went from, in 2024, we had 130 patients that were, that had financial outreach visits, and we've increased that to 350. So really strong program. This is a little bit of a busy slide, but really just itemizing the different resource that we provide through the financial navigation program. So that can be between different WIGs, through transportation. The South Lake Tahoe Cancer League has provided quite a bit of funding. The Reno Cancer Foundation has provided a lot of funding, double what it did last year. We have an ongoing American Cancer Society grant for lodging and transportation. And obviously we've also got our relationship with the Best Western, and we've had 294 nights that have been utilized through that. And I put a little star there for oncology support services. So you can see that particular line item is the massage, acupuncture, counseling, exercise for energy, and lodging, and that's supported through our foundation. So to give you an idea of what the foundation money looks like, this is a slide that was kindly sent to me from Carly, that gives us a flavor for how much the foundation provides funding for those extra supportive services on an annual basis. I'll just point out that it is financial year to financial year, so the 2020, we're already sort of dipping into the next year in the way that we're allocating the costs. We also are grateful to the hospital for providing catastrophic coverage for oncology care. So if patients come in and we have to quickly provide care, or there's gaps in care, and the hospital is able to provide that care through, a clear explanation of the situation, there is an opportunity for us to do so. It looks like we did a little bit more in 2025, but that's a little bit of an accounting difference. Some of that was actually from 2024. So it averages about $50,000 a year of catastrophic financial coverage that the hospital provides for patients in dire need situation. With respect to future planning, so there's a couple of things on our radar that we are watching really closely. The number one I put up here is competition. As some of you may know, that Barton is looking to open a cancer program. They have formally announced a relationship with Cleveland Clinic, which is not an on-site relationship. This is a remote relationship, and they're providing some advice. They do have an open position. We don't really have a lot more details, only to say that we're monitoring this very closely, and we've remained very committed to the South Lake Tahoe cancer patient population, and will continue to do so. With respect to critical equipment and capital funding, so the three main equipment needs that are very much on our radar is our radiation oncology LINAC accelerator. So there is going to be a service interruption for any service breakdowns after December of 2026. So we are at risk of service interruptions from our machine, and the potential risk of patient transfers out of the region. We do have a proposal, and we're hoping to get a exact date for when our LINAC accelerator will be replaced, and I think there's going to be other meetings that will address that. Our PET scanner is nearing the end of life as well. That will also need to be replaced. So we have this, as my understanding is, penciled in as a 2027 project. We do have for next year, 2026 project is our clean room IV compounding. That's a pharmacy project to get a second clean room hood for mixing chemotherapy agents. That's going to be embedded within the cancer program directly, and that's earmarked to be started in early 2026. And finally, I just want to thank everybody. I really, we could not do this without the support of the community, the board, the hospital, and we're really grateful to be here. It's an amazing place to work, and it's an amazing place and a community to take care of. And so together we shape the future of exceptional cancer care, and we thank you.
Oh, my God.
Thank you. Any comments?
Where do we begin in terms of a comment? My goodness, you're such a point of pride for not just everybody in this room, but the Cancer Center is a point of pride for everybody in this community. It's just remarkable. And I thought it was interesting that you said at the beginning that it's what did you call it? Not an aggressive, but a competitive team. And every time there's a bar that's been set, no matter how high or how far, you just blow it out of the water. So thank you so much for all you do and for what you do for all of us.
I've had the privilege of being a support person who was diagnosed with breast cancer and went along on her journey. And I do have to say, everything that you have said about the Cancer Center is true. When we walk in, they knew her name, they knew all about her. Every person that we saw that one day felt like they've known us forever, and in a good way. And she felt very comfortable. And then on the other visits I've had with her, she's always been so pleased with the care. And so I want to thank you. I want to thank you for the compassion that you've extended to her, because she came in. I mean, she has a husband, but she couldn't take him. She just, I don't want to support him through this whole thing. So she asked me to go with her so that she could, if she had a question, she could ask me, like, what did they say about this or that or the other thing? And so she's been very pleased with the care. And thank you so much, because it was an early stage and she is cancer-free.
All of us here live at somewhere between 6,000 and 7,000 feet. And in addition to that, most of us live here because of the tremendous variety of outdoor activities, skiing, hiking, biking, swimming, that exposes us to a lot of radiation, more radiation than the average person gets, I'm sure. I know it's anecdotal, but I personally and a number of my friends have had to deal with skin cancers. What is your thought about adding that service to what you're already doing?
Oh, that's a great question. I would love to have a dermatologist on staff.
I have been going to a dermatologist right across the street from the Incline Village Hospital. He's part of a Reno group. And I recently asked him that question. I said, why aren't you working for us? And he said, well, they haven't asked me yet. He said, I believe that there's enough business up here to have a Mohs micrographic surgeon available. He said, he said, based on what he sees. Now, again, strictly anecdotal. I have no statistics or anything, but I'm just tossing that ball into your court.
We'll talk about it. I appreciate the feedback.
Thank you. Before I make comments, anything, can I make comments to the public and then come back to the board? Or is it just simply?
Public comment is only strictly required if you're going to take action. There's no action here.
Oh, okay. All right. Well, then I can just talk then. Thank
Yeah.
you. You mentioned, I was taking notes, and you said what's so unique is the community. And I think of the community that built this cancer center, that continues to support the foundation, the people who live here and work there, and all the great work and the staff that you have. Thank you. I mean, it's just, I just feel grateful, during the holiday season, they just know that we can take care of our members here. I want to keep doing that. I'm competitive, and you said competition. Mm-hmm. So I see 25% South Lake Tahoe. Mm-hmm. That's a chunk. And from there, and so I think, again, I think of quality. I think of, again, part of me during a conversation, I'm like, oh my gosh, this sounds like Sloan Kettering. Like, why aren't people flying around from other countries to come here? Joking aside, being light about it. Yeah, good. All right, we need a bigger runway. I got it. I'll talk to the airport board. But all joking aside, it's. I mean, and you don't have to answer this. It's more just a thought in my head that as they build that in the South, and as we have an amazing community, how do we continue this great work for our community members and for those that, come from other places to continue? I don't have an answer. I don't expect you to have the answer. If you have something you want to add to that, I don't know, but it is something, as I think a board will be trying to see how we can support you.
Yeah, it's definitely front and center in our mind, because like I said, I lead it with, we're very committed to the South Lake Tahoe community, and they're part of our community, and we want to make sure they get great care. It is a challenge, and I think a lot of this is, built off the transportation issues. And so I understand the desire for Barton to create a cancer program. I think it is difficult to build what we have built here. I'm just going to say that honestly. It is difficult to build what we've built here. This is unique. It is special. It is very challenging to replicate.
Mm-hmm.
And I think people see that. But we're going to have ongoing conversations about this, as well as with our leadership.
Thank you.
Thank you.
Any other further?
I have another question. I noticed that in the presentation, there was a lot of reference to UC Davis as a research partner. But what other services are we receiving from?
So our formal relationship with UC Davis is to obtain access to clinical trials. So clinical trials that are open to UC Davis, we have the opportunity to open within our center as well directly. So they wouldn't need to go to UC Davis to get access to those particular therapies, and we select those very carefully based on what our population needs. We have a very close affiliation and a kind of a clinical relationship with them. We attend their tumor boards on a daily basis. We present our cases to them in collaborative format on a daily basis, and there are specific disease-focused tumor boards for that. And we get a fast track to getting those patients into appointments when needed. So when we have referrals, we have a way to have them be seen in that collaborative relationship that we have.
I knew there was more to it.
Yeah.
Actually, just one more question. Thank you.
have one more
You mentioned 500 new cases?
400.
Or, I'm sorry, 400 new cases. Is that trending up? Is that
No, it's about the same.
about the
Yeah.
same? Okay.
Yeah, every year. So that's what we call analytical cases, and we track that very carefully. It's reported to the county level, and so all of that is trackable. And if you had an interest, I could provide slides on what that looks like from a year-to-year basis, but it's really about the same.
Can I make one more comment?
Yes. You may.
Thank you. When we hear about all the wonderful programs and everything that's going on at the Cancer Center, I think that we would be remiss if we didn't at least mention the foundation and the wonderful work that is being done at the back of the room there, and all that is provided by the foundation. So thank you to them as well.
Thank you.
Well said. I'm glad I didn't decline that comment. All right, so this is not actionable, so it's just an item for discussion, so I don't ask for public. Thank you, everyone. Thank you so much.
Thank you.
Yeah, thank you.
Wonderful presentation. All right, we got more presentations. Now, the ACHC Primary Stroke Receiving Center Accreditation. Dr. Young and Julie Morgan to speak. And we've been not told much about. It was a teaser earlier today, so we are excited you're here. Thank you very much.
Oh,
Yeah.
Thank you all for having us. We're very excited to be here and very proud of our program, so we're happy to share it with you and kind of tell you what we've accomplished. I'm Abby Young. I'm the Stroke Program Medical Director, and this is Julie Morgan, our Stroke Program Coordinator. So first, we're going to start with stroke and why we care about it. We care about it because it can happen to any of us at any age, and it's the #1 leading cause of disability in the United States. It's the 5th leading cause of death, 3rd for women, and it's treatable and it's preventable. So stroke, or the fancy medical mumbo-jumbo of cerebral vascular attack, can occur in 2 ways. The first way is an ischemic stroke, and that's where you get a blockage to the arteries that take blood to the brain. Usually that blockage is a blood clot, and when you block the blood flow to the brain stops getting oxygen, and then you get cell death or brain cell death. The second type of stroke is a hemorrhagic stroke, and that's where the arteries to the brain actually break, and you get bleeding within the brain itself, and that also leads to brain cell death.
So ischemic stroke is what we're going to focus on today because it's the most common type of stroke. And it's also the type of stroke that we can have the most impact on here at Tahoe Forest Hospital. So that blockage of blood flow to the brain, it can be temporary and relieve on its own, and then the stroke deficits go away, or it can be lasting. And if it doesn't relieve on its own, it creates lasting deficits that can be quite profound and sometimes even lead to death. There are two ways to break up that lasting clot within the brain. The first way is a clot buster medication called a thrombolytic, and we have the ability to give that here at Tahoe Forest. You have to give that medication within the first 4.5 hours of stroke symptoms. The second way is what's called a thrombectomy, and that can only be done in very special types of stroke that are called large vessel occlusions, where there's a really big blockage in a big artery. And that can be done at Renown. That's where they actually thread a catheter all the way up into that artery, and they can suck that clot out. You have about 24 hours to do that. The last way that we can make a big impact at Tahoe Forest is just through prevention, through modifying risk factors that people have that can develop stroke, and then through starting antiplatelet or anticoagulation medication to prevent a stroke in the first place. So we say in the stroke world that time is brain, and we say that because acute stroke care is really a race against time. For every minute that there is a blockage to blood flow to the brain, 1.9 million brain cells die. And we have a lot of brain cells, but we don't want to lose 1.9 million of them. And so the quicker we can alleviate the blockage, the better. And we know that the sooner we can give that clot-busting medication, the better. In fact, it's about 3 times or 2.8 times better to give it at the 1 hour mark than to give it at the 4 hour mark. And that's why we say we really don't give it over that 4.5 hour mark, because it doesn't make a difference and it's just higher risk to give. So when we look at our community, it's unique in a lot of ways, and stroke is part of that. We have a full-time population of about 40,000, and then we have about double that in seasonal tourists, and they don't all just come here to get in ski accidents. Some of them come and have strokes. So we need to be prepared. And then we also have a higher population in both Nevada and Placer County of older and rural residents that live further from hospitals and that are over the age of 50 years old. And that is a population that's more prone for strokes. And that means that specifically in Placer County, we have a higher death rate for stroke than the state average. So about 53 per 100,000 versus 35 per 100,000 in all of California. And we live about 45 minutes from the nearest comprehensive stroke center, so that's renowned for us. And we all know that 45 minutes is on a good day without snow and construction and, assuming you're not in Emerald Bay. So that's, really quite a distance, and then we're getting really close to that 1 hour mark, even if you leave the second you have a stroke symptom. So these beautiful people, sorry, I get emotional every time. This is my family, and I didn't just put them up there because I wanted to brag. I put these beautiful people up here because those are my children in 2017 when we started the stroke program. And this was a few weeks ago before we had our certification. And you can see my youngest is now 8. The woman in the middle is my fabulous mother-in-law, Henny, and I put her in there because a few years before we started the program in 2017, she actually had a profound stroke. She lives in Olympic Valley, so not too far from here. She immediately recognized the symptoms. They called 911, and she was at our hospital within about 30 minutes. She had a CT. They identified her as having a stroke. And she was not given the option, or maybe she was given it but doesn't remember, and they decided not to give thrombolytics. She was then transferred to Renown at around the 4.5 hour mark, and at that point was outside the window to receive thrombolytics. But the neurologist at Renown gave her off-label thrombolytics, and she will tell you within about 10 minutes felt fireworks go off in her brain, and within 30 minutes was deficit-free. I, at the time, was not working here. I was working at a big academic center, and while I was really happy to hear of her outcome, I was really confused as to the care that she got at our hospital. And so when I moved here a few years later in 2015, I realized what exactly had occurred in her care at Tahoe Forest, is that we were struggling with the same issues that all rural hospitals struggle with as far as stroke care. We had a lack of public awareness about what stroke symptoms were. We had a lack of EMS education about where they should be taking stroke patients. We didn't have integrated protocolized care to really speed patients through the system. And we didn't have a neurologist on who could consult and advise whether or not we should be giving thrombolytics. We had limited imaging resources. At that time, we were not doing a lot of what we call CT angiograms to look for those large vessel occlusions, and we had limited hospital education and training. And of course, we had the ongoing challenges of being a fair distance away from a stroke center. And all of this, not only for Tahoe Forest, but across the United States, means that rural patients have a higher morbidity and mortality when they have stroke. So really, our stroke program vision and mission was born out of caring for our own family members, our community, and the people we work with. And we wanted to give them exceptional patient-centered stroke care, that they could really get the best care even though they lived in this rural community. We wanted to minimize their disability and maximize their quality of life. And although it was a process, we realized that we really had to do that by achieving recognition and excellence, both through the American Heart Association as well as becoming accredited as a primary stroke center. So this is our reporting structure for our stroke program. This is the current state. This is not how we started. We started initially in 2017 with Jan, who I bent her ear and said, look, we really can improve this. And she appointed me the stroke advisor. And at that time, we had a nursing advocate. And over the last 8 years, we really evolved to this more formal structure where we have a formal stroke program medical director, a stroke program coordinator, of course, the board supporting us at the top. And then under us, we have several teams, including our multidisciplinary stroke team, which we'll talk about here in a minute, our stroke operations committee, which is the directors and team leads for the stroke team, our multidisciplinary stroke review committee that meets quarterly and reviews all of the stroke cases, and our quality assurance program that really Julie heads and does a deep dive into all the stroke cases and metrics. In the last 8 years, we've developed a strategic plan that helps make sure we're financially and fiscally responsible. We've developed a lot, I would say 30, 50 clinical practice guidelines that help us provide standardized care and move our patients safely through the stroke process. We've done a lot of hospital-wide education and training in our stroke processes. We have a quality assurance and process improvement plan. We have really expanded the admissions of stroke at Tahoe Forest Hospital. We've done a lot of community outreach, and we've done a lot of development of our outpatient services to recapture our stroke patients once they're discharged. We have a lot of inter-hospital collaborations with Northern Nevada, Northern California, and specifically renowned as our comprehensive stroke center. And we've implemented a 24/7 teleneurology consultation service. And I should say, while it was Tahoe Forest that got certified recently, all of this has been implemented at both Tahoe Forest and Incline Village Hospital. Sorry, I went the wrong way there. Okay, I just wanted to briefly touch on our teleneurology service because they are really such a backbone for our stroke program. We work with a group called Telespecialists who has been amazing. They offer 24/7 stroke consults to both emergency departments in Truckee and in Incline. Their response time is typically less than 10 minutes, and I would say their average is probably honestly less than 5. They use a state-of-the-art telemonitor. We have 2 at Tahoe Forest and 1 at Incline that has a really high-definition camera that can track eye movements. The neurologist can move the camera around to do the exam and speak to the patient, family, the physician in the room. And they help us make those thrombolytic decisions, which can be very nuanced. In addition to that, they offer 24/7 inpatient stat neurology consults, not only for stroke, but for any other neurologic event that could occur within our ER hospital. They read our inpatient EEGs and outpatient EEGs, and they participate in our monthly internal quality and metric peer review. All right, so how does that translate to care in the emergency department or in Tahoe Forest? So in July of 2023, we went live with our stroke program and our stroke activations. And one of the first things that we kind of drill down is what we call the BFAST. It's an acronym to help identify the signs and symptoms of stroke. So B is for balance or imbalance, dizziness. E is for eye loss of vision or change in vision, double vision. F is for facial droop or weakness. A is for arm or leg numbness or weakness, and speech is for speech disturbance. So any of those would be a sign or symptom of stroke, and the T is for triage or time. If you're in the community, you call 911. If you're within the hospital or you're walking into the ER and these symptoms started in the last 24 hours, you get activated as a stroke alert. We educate this BFAST to every employee of the hospital during orientation. Registration, who is the first face of contact in the emergency department, gets additional education in this so they can alert our triage nurses immediately. When you are activated as a stroke alert, you really get a highly specialized, fast team. We equate them to a pit crew because they're going to come immediately to your bedside, and they are going to expedite this really complex workup to get you through the system as quickly as possible and get to a thrombolytic decision. We know that systematic stroke care is better and faster, and it improves outcomes. This is our multidisciplinary stroke team. We actually have 2 stroke teams, one in the emergency department and one on the inpatient side. So you can see all these people are who get activated and show up at the bedside and have to work together to get to that thrombolytic decision. This is our stroke alert workflow, and there will be a test at the end. I'm not even going to go through all of this. I just put it up there to show you that all of these tasks have to be accomplished before we can make a thrombolytic decision. And if you're thinking about we're trying to save minutes for brain cells, it's a lot. And so it's really important that we all work and dance together well as this pit crew. Our goal through the American Heart Association and kind of internally, we all challenge each other, is to give the thrombolytic or clot buster as quickly as we can. 85% of the time, the metric is to give it at the 60-minute mark, but we like to shoot for the 30-minute mark, and the goal there is 50% of the time. And then if we're not giving thrombolytics, or even if we do, we would like to have our strokes transferred within a 90-minute door-to-door. These are our metrics within the emergency department. We don't give thrombolytics an overwhelming amount, but when we give it really well. And our average door to needle time, so from the time they walk into triage to when we are giving the medication, is 46 minutes. This is what we call our Arrow Awards. We like to celebrate our teams that do well, and this is really such an interdisciplinary effort to get the patients here that we like to put these up when we have a win, and we celebrate the fastest door to needle times quarterly at our stroke meetings. So this just kind of walks through exactly kind of what point they were at and then who was on the care team that got the patient to their goal. These are the services that we have available now at both Tahoe Forest and Incline for acute stroke. We have a 24-hour ED and inpatient stroke team. We have 24-hour teleneurology service. We have 24-hour lab, pharmacy, and radiology. We have a state-of-the-art CT and MRI at Tahoe Forest. We have a comprehensive stroke alert clinical practice guidelines and thrombolytic care guidelines. We have transfer agreements with Renown, our comprehensive stroke center, and we have internal stroke resources. So all of our policies, protocols, clinical practice guidelines, tip sheets, the BFAST is housed on an internet page that any employee of the hospital can reference to reach back and see what the stroke flow would be.
And again, all of this is available at both hospitals.
The acute stroke services, are available at both hospitals. Tahoe Forest does inpatient stroke services only, that we don't keep those at Incline. And we have worked really hard in the last few years to develop a designated stroke unit, both in the ICU and medical surgical units, that has a designated stroke care team, including physicians, nurses, care coordinators, our therapies, our social workers, and dietary that are trained just in stroke care. And we have dedicated stroke education and discharge instructions. Both Tahoe Forest and Incline have outpatient and community stroke services. One of the biggest things that we've implemented is a care coordinator who follows all of our admitted and discharged and transferred stroke patients to ensure that all of their outpatient care is coordinated. We have expedited care through neurology, cardiology, and primary care, with our goal having stroke patients be seen within 72 hours. We have lifestyle and educational awareness programs for stroke specifically through Tahoe Forest, and we have community outreach, including the Love Your Brain support group and yearly hospital day and events. We also have implemented the Tahoe Forest stroke community page. I'm not going to go into it tonight or show you tonight because we don't have a lot of time, but if you Google Tahoe Forest and stroke, you'll see a beautiful community-facing page that has the BFAST on it. It has a little video about our stroke services and what we offer here. I'm going to let Julie talk a bit about our metrics and how all of those programs have translated to really excellent care for our community. She does an amazing job kind of drilling down monthly on all of the patients we see, where they get discharged to, and if we've met our metrics.
Thank you, Dr. Young. Thanks, everyone. So just really quickly going over a couple of metric slides, not very many, but like Abby said, Dr. Young explained, our program initially started with nothing, and then now here we are in 2025 at the end with our ACHC accreditation. So this slide basically just shows how do our patients arrive that are diagnosed with stroke or are a stroke alert or a modified stroke alert. And you can see a majority of our patients are in the gray there. Those are the walk-ins, triage patients, right? But you look at the numbers in the blue, those are our EMS arrivals. And so prior to the implementation of this program, and actually prior to the ongoing education with local EMS and the push with that, those numbers were 0. All those patients were being bypassed from our facility. They did not bring those people to us. And so now you can see, we see anywhere between 8 and 15 patients a month arriving via EMS to our facility. So these are our local people that want to come to this fabulous hospital. So we're happy we're able to care for them here. Just a quick kind of busy slide, but just a little bit of how do we use our telespecialists. So that big tall line, the blue one, that's the number of times per month that we use telespecialists here. And that's stroke alerts, that's stat consults, those are those neurology rounding, the doc to docs, et cetera. So we use it a fair bit. When we first started the program, those numbers were in the 15 to 20s, and now we're easily at 60 almost every single month, obviously depending on how many people are in town. And then you just kind of go through of how many times are we using as a stroke alert, which is your orange, how many times do we do stat consults, routine consults, doc to docs, and then our EEG. So we're using it a fair bit, and telespecialist is an amazing partner for us, very successful communication and collaboration between our program and telespecialists. And then this is probably the most important slide for everyone watching and for me and for all of our stroke patients. These are our disposition metrics. So this is how do you leave the hospital once you've been admitted here or come into our emergency department. So just remember, prior to our program go live, these people did not come here. They were either bypassed via EMS, they arrived as a walk-in or a triage patient, they were worked up quickly, and then they were immediately transferred. Now you can see these numbers. The blue number is how many people we admit here at Tahoe for stroke-like symptoms. So you can see those numbers easily 15 to 20 patients a month are being admitted here in their local community. The other 15 to 20 patients or 10 to 15 patients are being worked up in our emergency department and are being discharged to their own homes here in Incline, Tahoe, Truckee, et cetera. And then we're only transferring 1 to 3 patients a month down to Renown, whereas prior to our program go live, every single one of these people would have gone to Renown and been transferred down there to sit in their ER and wait instead of being here at the best mountain community hospital, right? So very proud of this program. A little bit more about how we went through. We initially started with nothing, and then we organized with American Heart Association, Get With The Guidelines Rural Accelerator Program. You have to meet certain metrics. I won't bore you with those, but we initially did that the first quarter. We met our metrics, and all of our data looked great. We received a bronze certification. Then within the next year, in 2024, we maintained our bronze and met all of our metrics, which gave us the silver accreditation. And then in the beginning of 2025, we had met our silver credentials for an entire year, which gave us the top accreditation certification, which is the gold for the American Heart Association Rural Stroke Accelerator Program. We consistently hit all of our metric benchmarks and maintain a total composite score of 92.3%. Pretty darn good. I'll let Dr. Young finish up.
I was also just going to add on that kind of AHA stuff, even though we focus very heavily on Tahoe Forest because we are part of the Get With The Guidelines. Incline, we have not done that only because of the call schedule for radiology and lab to be called in, that we would probably fall short on some of these metrics. But the AHA has recently given Incline a grant because they've been so impressed with the care that they receive, which is $12,000 a year for 2 years to develop the stroke program there as well, which is pretty impressive. All right, so on to the accreditation, which was in November, just a month ago. Seems like a while ago. And it was a full-day event where the ACHC came out. We gave them a program overview. They went over all of our documentation, our clinical practice guidelines. We gave them a hospital tour. They interviewed all of our stroke teams, and they did a deep dive into all of our charts. And they found that we had 0 deficiencies. And we are now certified as a primary stroke center. They were so impressed that they've asked Julie to speak in 2026 at the ACHC conference. So just to kind of toot our horn a little more, there's 1,385 critical access hospitals in the United States. 10 of them are primary stroke centers, and now we're the 11th. There's only 37 critical access hospitals in California, 4 of which are primary stroke centers, and we are the 5th. So we have a lot of future goals and initiatives that we still want to work on. I'll just kind of briefly run through them. AI Doc is the kind of big push, I think, coming into the new year. That's a artificial intelligence program that we're partnering with Renown to identify strokes and specifically those large vessel occlusions early and get those patients transferred down there as quickly as possible so that they can have that thrombectomy or mechanical extraction. We also plan to work more on our obstetric and pediatric stroke clinical practice guidelines. We, of course, are going to maintain our ACHC accreditation and our get with our guidelines status and benchmarks. We are also going to, or Julie's going to present at the AHA International Stroke Conference. And then we are really going to push for our outpatient care coordination and improving access to care for our stroke patients once they're discharged. And, of course, continuing education and training for both staff and our community. Our goal is really to provide the best care that we can provide for our community that we live in. Thank you guys for having us.
Wow. Thank you.
Yep.
I'm a little speechless for a moment, but I'm sure I'll find some words.
I'm sure you will. Congratulations on this recent accreditation. I mean, that's certainly well, I guess you're going for platinum next, right? But yeah, I mean, this is just remarkable what you've done, and the real beneficiaries of all of this are the people in the community. And I just think they are so fortunate to have this program that can have such a profound effect on their lives. So thank you so much.
Yeah, I'm really excited at the fact that we're accredited now, and that in the United States, we're number 11, and in California, we're number 5. So again, kudos to all of you who've worked on it. It's been an amazing journey for you and a great learning experience, I'm sure. And your sharing your story with us has been just a realization that we are the best. Thank you.
My wife and I consider Henny to be one of our very good friends. You probably know that.
I do.
Yeah, okay. Remarkable stuff. One question that I have is that if you do a test here, an MRI or CT scan shows a block, and you know that block's got to be surgically removed, then you hustle them off to Renown at that point. Is that the idea?
We do, but the research actually shows that administering thrombolytics or the clot-busting medication can be done safely and is more effective even if they go on to have the thrombectomy. So we would still give thrombolytics here if they're candidates, and then we would quickly send them to Renown. And that's part of that. We do it quickly now, but we would like to be able to get that transfer to occur even more quickly through the AI Doc system, which would basically work with our CT imaging and notify their doctor on call that we have a large vessel occlusion in our facility so that they could start spinning up their team before we even make the call.
Right, yeah, okay.
Thank you. I think of your mother-in-law in Little Big Valley, and like such a devastating event, and being in such a remote place, how scared that could be. That like I am on a trail, I'm in a mountain, I am somewhere where it's snowing, and this is coming to happen to me, and and I think of how far that care is. And so thank you. So take that stress off, that it's close at either of those hospitals to get world-class care. And that's a lot of work. That's a lot of diagrams. That's a lot of people in that diagrams. And I'm reflected to that dance of all those people. And I think of, the nurse, the triage nurse, the nurse that's there, the tech, the lab draw, the radiologist, the physician, all those people working in concert. Because that first, when you said we're not going to test us on it, thank goodness for saying that. Yeah. But saying oh my gosh, that's so complex. How do they do that? But you look above that slide, and you see that entire team knowing what they have to do, how well they do it, and it is truly it is a beautiful dance to say, or a pit team that really helps that patient get better. So, and that is a lot of work, of people in the room, and I can again think of everyone who's been part of this. So, thank you for presenting that.
And I think sometimes it's interesting for these people just to walk them back. They're terrified. They don't know what's happening. You're trying to get them back to the bed. Then you've got to get them completely undressed and into the bed, and then down to the CT scanner. So just think about how long that might take. That could take 10 or 15 minutes. We only have 25 minutes to get the first image, and we need to give them that thrombolytic, ideally within 30 and definitely within 60. So it is definitely a rush, yes, while you're trying to be as calm and caring as you can to that patient who's terrified and is like, why are you getting my shirt off me so fast? Putting me in this gown. We need to get you down to the scanner. So it is definitely a dance, and this team is exceptional at it. And I know at Incline Village, they are also exceptional. They monitor the stat as well, and they meet all their metrics as well. So.
And there's two more things I just remembered. That one is reflective of the people that we do keep here. I remember talking to hospitalists here, and they're saying we're seeing so much more stroke. We're able to manage them. Mm-hmm. And I think of our 5-star CMS, coordination of care, because it takes more than just, you come to the ER and I went to the emergency room or the hospital, I had a stroke. There's so much more after that. There's so much medication management. There's so much more testing. There's so much more rehab. There's so much physical therapy. And where else would you want to have that than a 5-star, coordination of care? 72 hours to see your clinician, because that's really, a lot of these small strokes, I'll tell a patient, it's just, the reason you're doing all this because we don't want the big one to happen, and to prevent that. And some people may look at that and say, oh, it's a 1 per month or what have you. That's a lot of, so many resources, but the debilitation and how much it costs to take care of someone has hemiplegia, who's completely paralyzed is, it's truly, financially, it is what's needed for this community. So
I will say the ACH surveyor did recommend that we invest in a second scanner, especially with our trauma program where it is right now. If we have a polytrauma on the table that's getting pan scanned, so they're getting every scan throughout their entire body to ensure that they don't have some kind of catastrophic traumatic injury, takes a significant amount of time. And if you're the one that comes in that has the stroke symptoms, we can't just yank that trauma off the table. So she did recommend we invest in a second scanner. So if Dylan can just start building that.
and then they gave you a nice big fund for that, right? Nice check for that one too.
They wrote us a check.
Oh, of course.
Floor of the Incline Hospital.
I like the way we're thinking.
Are we more at risk here in the altitude?
Oh, that's a good question. I don't know statistically. I think we're just more at risk here because of our distance to care, where we oftentimes are. But I don't know if there's a statistical risk to altitude.
So there is, because blood pressure tends to go up in altitude, and blood pressure usually drives stroke.
Yeah, I would agree with that. I mean, we see anybody that's coming up from the Bay, we see more decompensation of their heart failure, more heart attacks.
More atrial fibrillation.
More atrial fibrillation. So I think I don't know that there's been a study, but I think it's probably true.
Blood pressure there is the documentation.
Yeah, but specific for stroke, I don't know.
Right.
Yeah.
Okay.
Any other? All right. Thank you so much.
Thank you.
As they say, but wait, there's more.
Yes.
I feel like,
The next exciting.
yeah. Well, thank you. So, I just, again, those two are amazing presentations. I'm looking forward to this third one, to listen to Patient and Family Advisory Council presentation. Alex and Amber, thank you so much for coming and to hear about our presentation accomplishments of the PFAC. Our community members, those that we do this for.
Yes. Really hard to follow up those two reports. I will tell you our accomplishments this year. So I'm Alex Bezaire. I'm the Clinical Patient Experience Advisor here at Tahoe Forest. I also have the privilege of chairing and facilitating our Patient and Family Advisory Council. And with me is Amber Mello, one of our volunteers on the council. And so I will let her also kind of help share some of the things that we discussed this year. But I guess to start, 2025 was kind of a transformative year for our PFAC. We had significant advancement, I feel, in our collaboration and engagement with the health system. We kind of had a good, strong discussion with a lot of our leadership about like how do we engage our group better. Our group really wanted to make sure that their voices were being heard a little bit more, their ideas and input were being a little bit more immersed into our process improvement initiatives. So we really worked together to make sure that we were getting them a little bit more engaged in some of our committees. We did some changes to our meeting structure, so we did come up with a standardized template to kind of help guide when our presenters would come to us with seeking input and asking questions. We wanted to help guide them to help identify the challenges within their departments so that we could help give them the feedback that they were looking for. We did add a member. We had Bob Barnett, former director, join the PFAC, so we're super happy to have him. It brought us to 11. We did have a member actually just leave last month, but then we have another one that we're onboarding right now, so we're still at 11. We actually designated Alan Kern as a co-chair. So he's helping to run the meetings, and he's also part of our IT Clinical Governance Committee. And we identified a need for additional meetings. We wanted to meet and hang out more. Historically, we took off for July, August, and then December. Part of that was just school schedules, people traveling throughout the summer. But we felt this year that there was a lot of really good momentum and wanted to keep that up. So the group opted to continue for July. We stayed off for August, and then December we have decided to keep that one off too for holidays. So a lot of our council members, our volunteer, we've got a really core group. I think that's what's so great about this group. This is kind of the OG community outreach group. So we've got 11 people that have all been sitting on for just about 2 years. So that's a great part about this group is it's really consistent voices, people who get along really well, a really good cohesive dialogue. And really the volunteers are the ones who serve as these community liaisons. They're really the bridge between the health system and the rest of the community. I guess I should be sorry. Some of the subcommittees that we have been able to incorporate some of our PFAC members in is the new IT Clinical Governance Committee. The Board Quality Committee, Med Staff Quality Committee have had a PFAC member on that for a long time, so we've continued that. And then we also have one sitting on our Patient Experience Committee too. So I'm gonna let Amber discuss kind of our feedback.
So I will say that I think that we've been so energetic since the new agenda and kind of meeting format that has changed that I've noticed. We're a pretty diverse group of people and with a lot of different backgrounds, and you may have heard about us, so I won't go into that too much. But what we did this year was really interesting. I joined PFAC for my own personal reasons, but had my own issues and feedback to give. And I've been energized and really have enjoyed being a part of the group and have felt really heard. And it's a really lovely group of people to problem solve with, and all of the staff members that we've interacted with. I think I'll go through the meetings that we've had, but one common theme is that each staff member that's come to us or provider has had a really good understanding of the issues that they're facing and what they want to troubleshoot with us, which has been really helpful. And I think that's in part to Alex. But I'll just go ahead and say that in January, we went through the adverse event process and case review. That was really interesting to hear about, even the parts about like psychological safety and making staff feel comfortable with raising when an issue has occurred. That was a really interesting meeting. In February, we learned about therapy services. So, and we talked about appointment reminder systems, and we proposed implementing a cancellation no-show fee, and in part because the therapy services department had a lot of no-shows and like higher percentages than other parts of the system.
Consistently, too.
Yeah, consistently. Yeah, consistently. And so I believe they circled back with us and they have implemented a system. And that's another great thing that's been happening is we've been getting a review of how things are going from the feedback that we've given and the trials that they've been sorting out in each of the programs. The March meeting, we talked through the meeting structure, like Alex mentioned, and to really focus on providing feedback and not just being a listening committee, but or like a kudos committee, but hey, we're here, we're patients wanting to help, and we each have our own backgrounds and expertise. There are some people who have been in the medical field. There are other people who are not in the medical field but have other helpful experiences that we can provide feedback on. So I think everybody on the PFAC is just hoping to add value, and so I think that's what the meeting structure kind of changed to that format. In April, we went through, access to care. And that was, I've been on the PFAC for about a year and a half now, but access to care has been a recurring theme in those meetings. And so we were able to focus back on what they had spoken about in the past and see some of the data change in a positive way from different tactics that they were implementing. And then I think, and I believe Access joined a few meetings of ours actually, because there's so much intertwined themes with some of the other department issues and that we were talking about and access to care. In May, we talked through leadership engagement and again, like that accountability and curiosity to problem solve with us. And Anna was able to join us and has joined us a few times. And that new energy and with a new leader has, I think, been one of the reasons why PFAC has been like, hey, we're on a roll. Let's just keep going. So in June, we talked through behavioral health services and the referral process, with the goal being to convert 50% of referrals into scheduled appointments. The future goals being to improve and expand support for patients beyond the Tahoe Forest offerings.
The behavioral health service line has grown exponentially in the last couple of years, so it was a good opportunity for them to come to us. I don't think they have actually ever been to any of our meetings, but just to really show how much it expanded, because early on, a couple years ago in PFAC, we had identified mental health, behavioral health services was kind of a gap or deficiency in the community. So with that, it was really good to hear from them, to hear how much has changed since that.
Mm-hmm. Yeah. And then for July, we again spoke about access and scheduling, and there are a lot of really great happenings with the scheduling technology, and we were able to get insight into that. One of the things I really like about being on the PFAC is just how much I get to learn about what's actually happening at the hospital. Even this meeting, I'm like, wow. So I had heard about quite a few of the initiatives that I've heard about today, but but in like snippets, and it's just really wonderful to kind of hear the enthusiasm of the staff and the pride and the competitiveness. I didn't realize that you doctors were so competitive, but I'm super stoked to have this bunch. Like, I want to be on your team, you know? So it is really inspiring. But, you know, part of, just being able to be an ambassador for the programs that Tahoe Forest is putting out there. And then in September, we got, again, a follow-up from the therapy services, and we shared about scheduling issues, and which is honestly, you know, scheduling issues, it might seem, and I know everyone here knows that scheduling issues are nothing to balk at, but when I think about scheduling issues, it's like the timeliness, it's the care that the patient feels like they're getting. So it might seem like it's just scheduling, but it's a lot more than that. It's attentiveness and prioritization, it feels like, to a patient. And then October, we talked through the kind of that True North initiative, which was so interesting, and talked through the action planning, or the action force that was being created from that, and a few of us were asked to be on it. And then in that meeting, we talked about the like just improving visibility into the community webpage, which was just incredibly interesting. And I don't know if I would have found it had I not been on PFAC. So I've been even able to pass that along to some folks that I know, and I'm sure people are, more people are getting access to it. And then in November, we talked about wayfinding, which was really interesting, actually, just kind of going, like thinking about the expansion of the hospital and the health services and what that could look like. And then even talking through some of the blockades of doing certain things for different reasons. But it was a really lively discussion, and I think wayfinding around a hospital or a healthcare system when you're not feeling well is a really important part of a patient experience. So that's the year.
Thank you.
Dylan's here, he can speak to it, because he was the one who presented. But wayfinding has been a sticking point for a lot of patients. It's an area where I get a lot of feedback. I see a lot of comments, and actually, and I don't know if we all hear about it, because we all know our way around the system. We're all from here, but a lot of people new to the area or haven't been here in a while and aren't familiar with, we have doctors moving all the time. Providers are always constantly moving, so being able to keep up with the shuffling is really difficult. So, you know, just simple things like having a building name or a building letter. And everything is on Donner Pass Road. Everything is at 10121 Pine. So it makes it really confusing. Or you say, go to your appointment, it's on the second or third floor. But it says second or third. You're like, well, which floor? So things like this, these are the things that I think we can help clarify, because that is what starts that patient experience. And if they're mad because they're late, because they couldn't find the building, it's not going to start off well.
Parking place. Yeah. And it's going to get worse with the advent of the Rite Aid building and the
Right.
Gateway
Exactly.
and the Dollar Hill over in
Yep.
Tahoe City. So, yeah, I'm hoping you guys can come up with some real clever solutions.
Stuff. I hope, yeah.
So you're a skier, you were mentioning. Alex has this really good idea about having, you know how you have like the app on your phone so that you can see yourself on where you are on the run? I'm giving a plug for Alex's idea.
Interactive like trail.
So when you said that, I was like, and you could even like name certain, anyway, you can really go wild with it. But I really liked that idea. And, you know, just in these meetings, we've had a really fun, you know, we're talking about some serious issues, but we've had a lot of fun discussing them. And I think we're all really enthusiastic about just having Tahoe Forest be a good experience, even if you're not in a good situation. So, yeah. Thanks for having me.
Yes.
That concludes my section of this.
And we've got a possible recruit in the house, Danny, so we're trying to look really good so that he'll join perhaps. Our plan for 2026 is just to continue the good momentum that we've started to build up right now. I think everyone's really excited to be able to report back on their particular committees that they're sitting on. It helps strengthen the trust too in our services, the more that they're able to be immersed. We just want to make sure that we're being seen as the primary resource for any process improvement initiatives. If there's a new beta program or something that you just want to test out usability, and we have got a group of people who can test it out for us, So we get people who can maybe secret shop if we're looking to do some customer service audits, various things. So, it's a really engaged group that really cares a lot about the health system because it's their health system, and we want to make sure that we're just continuing our patient-centered care. So.
Question. After every appointment we have here as a patient, we get a survey request. In everything we do, we get surveyed, don't we? But a lot of the questions are yes or no. But there is a comment block. And I assume from time to time that people fill out that comment block and say certain things. Do you have access to that so you can contact these people and get their questions, comments, whatever they have to say and do some follow-up that way?
Every comment is read. They're dispersed. They're all online and available for all of our leaders who have access to Press Ganey to review.
Okay.
So most of the surveys are interesting because patients have the opportunity to leave their contact info or not. So it's usually under the guise of anonymity. It's anonymous feedback that we take and, make process improvements from it, learn from it, educational opportunities. If they leave their contact info, that is an invitation for us to contact them, but if they don't, then we just have to accept it and be receptive.
Sure, okay.
Of course.
That is something that you kind of, not the maybe specific comment level, but it does come to the board, like at a very high level, when Alex brings the patient satisfaction and the, sometimes the grievance stuff that comes, it may not be like, a specific comment may not come to the board, but she's looked at every one of them, and if there's like something very unique, she may actually send it to, did you all see this? So it does make its way up and down through the organization. Just maybe not word for word at the board level, but you kind of get the overall.
Well, that's great, because otherwise you have to rely on your own personal experience, and that could be very limited. Yeah.
I think a lot of people always wonder, does anyone read these comments? And we do. We definitely read them. So we appreciate when people take the time to freehand some comments.
There could be synergy between those comments and PFAC in terms of, taking them to PFAC and saying, what do you think? And help us problem solve these things.
Yeah, but there was a time when I was bringing forth some, not specific verbatim comments, but complaints or trends that I'd seen or heard about and kind of bring to the PFAC glove. How would you manage this, or if this were you, what would you want to see? So I think that would be something good to revisit again for 2026.
Great.
Okay. Any other comments?
No.
Yeah, I have one on, when you do have leadership that comes and speaks about their challenges and you give recommendations, I know in the past there hadn't always been a follow-up. They wouldn't come and say, well, we tried it and we found that we did it better this way. But it sounds like you're getting feedback now, which really stimulates you more to give some ideas of what could be done to help alleviate the challenge. And it was really interesting when you brought up about wayfinding, because I've thought about that over and over. Like, why can't we do an app on this? Because people will ask, well, if I'm here, where do I go? And fortunately, sometimes we have a volunteer out there and Maria will walk you over to where you want to go. But wouldn't that be fun to have an app that says, this is go down this side, go over this way.
Yeah, turn right, turn left.
Yeah.
And I'll bet some way you can add QR codes to it. No, but I mean on buildings or whatever.
Oh,
That came up too, actually.
Yeah, I mean, it's interesting. There are a bunch of different solutions to these problems, but it's fun thinking about what could be, and it's very hopeful feeling as a council, and hopefully the staff, I've been a part of some feedbacks sort of loops through my own work, and the goal for me at least is that any staff that comes to us feels more hopeful with our conversation. So I hope that continues, but it's definitely hopeful for me as a PFAC member to see the problems kind of coming back to us, like you're saying, and that follow-up, and see how things go. And even if they don't work out, seeing why and figuring it out with them again.
And the larger your group, the more different ideas come out. And one of those is going to work. It's just a matter of going through that problem solving to say, okay, this and this one and this one, and then figuring it out. But the more ideas you have, the better chance of finding the answer.
I mean, these folks are thinking about it every day. We think about it once a month, or maybe like once a year. But if we can provide a little spark of something, I'm here for it.
Thank you.
Thank you, Alex. Thank you for giving
your
us the
volunteer work. Go.
Well, thank you, Alex.
Yeah.
Thank you, Alex, for always bringing the high view again. As I think Anna Roth said it so well, that we do have a kind of this big high view of seeing that. So thank you for continuing momentum, building this. It's lovely to hear. I'm just always reflecting. This is my second time I've heard this, because it's 1 year since I've been here. And Amber, I want to thank you so much again. So because we were at the high level, we don't really see behind the curtain, but your stories really just pulled back, like what happens at those meetings, your experience. It's so important for us to hear that and continue hearing that. So thank you for taking the time. I think someone told me one time that this is one of the most regulated businesses, right? You're giving care to someone, and yet it is the most regulated business to make sure that everything is done properly. We don't hurt anyone. The best care is given. And then you throw on that these are just humans who have had a bad day. They're under stress. They're trying to do everything right for the patient. And so your journey and just what you said about I see this side as well thank you. Thank you for coming. It means a lot, I think, to everyone who works here to know that, the PFAC is understanding. We're understanding the journey, because you have to bring your best to the patient every time. And that's hard, and that's, everyone wants to do that best they can. So thank you for being part of it. Mm-hmm. Thank you for your report. Mm-hmm. All right, that's the end of the page, right? Are we done?
Now, turn the page.
Turn the page.
All right, now we have work.
Yeah.
Now we have an action item. No more presentations. 16.1, Memorandum of Understanding. The Board of Directors will review and consider approval of a MOU between Tahoe Forest Hospital District and Tahoe Forest Hospital District's Employees Association of Professionals, Tahoe Forest Hospital District Employees Association, and AFS-CME Council 57, Local 3254. So Louis and Anna. Louis, are you up for this? Thank you. And is Lauren?
Oh, I'll give you two the floor again.
Actually.
This cured my insomnia.
This what?
This cured my insomnia.
Oh, yeah, exactly, yeah. So this is, in reflection, just obviously, everyone who in the public can know, this was obviously, there's a closed session, obviously, this is now open session for this item, so, thank you.
Well, thank you very much for having us. Good evening, board. I'm here just really to introduce Lauren Caprio. Sorry, excuse me. Lauren has done a wonderful job working with her team, as well as working with the union, the EA and the EAP, and they have really came at it with this spirit of compromise and just vigor and relationships. So we, of course, did present the MOU earlier today, and wondering if you have any additional questions before taking action.
I don't have any additional questions. I thought that was a very thorough discussion.
I enjoyed it.
Yeah.
Yeah.
I did.
Oh, good.
I did. No,
As you
I would
should.
like to say, it was interesting hearing from Julie as well, because she sort of reiterated that it was a very positive and well-trusted, just a very, very great experience working with you and in the spirit of compromise.
I agree with that sentiment of hers, and I really do look forward to continuing the work that we have done with the union and the growth that we've made, and seeing them at the table in 18 months.
Right.
Yeah? No, I think, very well said, Mary.
Yeah.
There was so much that was done during closed session that I think I echo those exact same sentiments. It's lovely to see people working together, working for a common cause, and it was very well presented, and so I think we have no questions at this point. And I think we're ready to make a motion then. Comments from the public. This is the opportunity for the public for any comments. Okay. Then we'll go ahead and make a motion.
I move that we approve the memorandum of understanding as presented.
I would second that motion.
All in favor?
Aye.
Any opposed? All right. Thank you so much.
Point of clarification, are we going to, as a board, approve the document when it's completed, or we've delegated that to you?
An authorization for me.
Gotcha.
It's in-
Okay, thank you.
Is that
Do you need the first motion to be specific to what you recommended in the cover sheet? The EA, the EAP, and ASME, Council 57, Local 3254 as presented?
Mhm.
Okay, and then do you need the second motion to be allowing Anna Roth, President and CEO, to execute after?
Yes, why not?
I would make that motion.
Yeah.
I think it's reasonable to get clarity and make that motion.
Thank you, that's
So
what I
We
was
should make a
asking.
motion to
I
allow.
would make a motion to allow Anna Roth to sign on behalf of the board.
Okay.
I'll second that.
And
Okay.
MOUs vote their approval.
Okay.
Yes.
Thank you.
After the MO.
Which will happen
Oh, first the
tomorrow
MO.
for 10 days. So the vote will be open for 10 days. Once the union, hopefully when they vote it in, then Anna will be able to execute the contract. Mhm.
So the memorandum of understanding will become a contract.
Exactly. So right now, it's considered a tentative agreement.
Gotcha. Okay. What's the likelihood that they'll come back and say, oh, we'd like to make a modification or two?
Well, it's been tentatively agreed to, so if they were not to vote it in, so at this point, they can't come back to reopen negotiations. If it was not voted in by the membership, then we go back to the
Negotiation.
table.
Okay, okay.
But let's not think about that.
No, okay.
So I believe that Mary made a motion.
We're positive.
Alice, second.
The first motion to include all of that? Or are you?
No, I'm making a second
Two
motion.
second.
I'm making a second motion.
Thank you.
So we've completed a first motion to approve them. The second is to now allow our CEO and President,
Authorize Anna Roth.
our CEO and President to execute. And Alice, second, correct?
Yep.
Thank you.
Okay.
Okay. All in favor?
Aye.
Aye. Any opposed? All right. Thank you so much.
Thank you so much.
All right.
Thank you,
Thank you
Lauren.
for all your work.
Thank you.
Woo! That was a lot of work. All right, we will skip 17 since there's been no consent calendar items pulled. Board committee reports. Board committee report items.
We didn't have a,
Okay.
well, we had a party. I guess I can't
No,
report
we
on
had a
the
meeting.
party.
That was a meeting.
Well, yeah, that's true. We did have a meeting, but not at the hospital, at the home of Julie Teal. We met and discussed a number of items and have no specific resolutions.
Thank you. Any other? I know that I was invited by Elizabeth Maria Martin to attend the Community Health Improvement Plan, correct? CHIP. No, there's so many.
Yes, Community Health Improvement Plan, the CHIP.
The CHIP, which is funny as a board member, because in June, we'll be hearing the CHIP to approve it.
Right.
So it's a little awkward. It wasn't awkward, I just felt like, oh, interesting. Things that I learned that I'd like to share with the board is there's also county CHIPs. So Placer County is a CHIP. I'm a new guy, so the mayor's like, yeah, Rob, now you know. So, so it is interesting to hear alignment from there. I think the other feedback that I can give is that it was just amazing. I mean, it was in this room because, yes, it was in this room, and obviously it was completely horseshoe filled, and you had people from education, from TTSD, we had transportation, we had mental health, we had Sierra Community House, we had our hospital leaders, and it does, as they say, it does take a village. So I thought it was really fascinating to hear, even transportation weighing in on how we can get, to build this. So there are more meetings to come. It was really more of a kickoff, who's getting what responsibilities, how we're going, and so I asked to be invited back. I hope I will be.
Did we count those in our voices?
Yes,
Yes.
it is in the
Actually,
code.
it
It
is
is
in the
actually in the
voices.
voices,
Okay.
yeah.
Yeah, it
22 or
is.
something like that.
Just checking.
Yeah.
It was a good amount.
22 and headed straight for 5,000.
Wow.
Well, thank you. All right, board members' reports or any closing remarks? Obviously, there's the Brown Act, so we have a chance as board members. Any reports, closing remarks, anything you want to tell each other
No, I
while we're here?
look forward to reading the new Brown Act,
Yeah.
see what that holds for us, but obviously wishing everybody the very best of the holiday season.
Thank you. Thank you. Yeah?
I'd like to hear a report at some point of our efforts to get a chief of HR. So,
We can bring that back, but I can, if it's okay with the chair, I could.
I don't know if, it's not agendized,
Yeah,
but,
since it wasn't agendized, it would be best to bring it back later when the public has a chance to know it's coming.
okay,
Okay.
that's all right.
All right.
That's all.
Okay. I have one comment, and that was, let me catch up for a moment. Now I forgot it. It'll come to me. All right, but, there was one. Oh, actually, I want to, the remote parts was that, as continued board education, we did receive board education via email, and I think it was very fascinating. I hit, by accident, I hit the little button in the corner, which was the AI summary. I was like, wow, it's really nice to summarize 20-some-odd pages, but it was really fascinating as a board. Our job and what we need to continue to do, and obviously not just the fiduciary responsibility, cybersecurity, making sure that we keep our hospitals quality, all the things we do. On one hand, it was, as we get as a board, we learn more, and it changes with the Brown Act, we adapt to change. It's just nice to always continue our education, so I just appreciate it. And then the last part I'd like to say is, Alice, it's the end of the year,
And I wait for this every year.
and I would love to give you the moment and time to speak.
Merry Christmas to all, and to all a good night.
Thank you, Alex.
All right, no closed session, and then, that's it. Looks like 20, and we may adjourn at 8:21.